Assalamu alaikum. Hello, dear friends. This is one of a series of videos about hospital policies and procedures, which are written instructions on how staff members do different processes. Policies are general rules that govern our performance, and procedures are sequential steps on how we do it and the responsible person for each step. We can update these rules when we have new standards to follow. In this video, we will talk about patient transfer and referral policy. For more videos, please visit my Facebook page, Healthcare Quality, and my YouTube channel, Dr. Hassan Kamel. If you like it, please support me with likes and follow. This policy applies to all employees and other personnel involved in the referral of patients within and outside our hospital. The purpose of this policy is to set guidelines to be followed whenever a patient is to be referred for consultation, treatment, and/or transfer, both within and outside our hospital. Definitions. Internal referral is a referral of a patient within the facility. This may be intra or interdepartmental. External referral is a referral of a patient from our hospital to any other healthcare facility or vice versa. Emergency case is a patient presented with a life-threatening medical condition. Specialty clinic is a clinic run by a consultant, which may be departmental clinic, for example, pediatric or OB/GYN, or a subspecialty within the department, for example, ENT in surgery department. Policy. It is the policy of our hospital that all referral, internal and external, to and from the hospital should be according to the approved process implemented by the Ministry of Health. First, internal referrals. All interdepartmental referrals and responses, except emergency department doctors, should be appropriate to approved MOH consultation forms. Interdepartmental referral procedures will be as agreed upon within the department. The consultation form should be completed in legible handwriting and should contain clinical and addressographic details. A. All internal emergency referrals should be supplemented by direct telephone contact between consultants if practicable. To do so is preferable for the referral to be made by a consultant to another consultant in the desired department. B. A resident or specialist may write the referrals on behalf of his consultant, stating, "I do this referral on behalf of." Consultant in charge must, however, be aware of the referral and is accountable for it. Only consultants may respond to referrals from consultant colleagues. However, if a consultant is busy, he may assign his specialist to see the case if an urgent response is needed. However, the consultant should review the case as soon as possible within 24 hours. For serious cases, it is advisable that the consultant should see the case himself or herself. All referrals should bear the signature and the code stamp of the referring doctor, as well as the time and date the referral is made and the time the referral is received. C. Referrals in emergency department. The emergency department doctor may refer patients directly or by the telephone to any specialty on-call team. Where possible, before referring the patient to a specialty, the specialist and/or consultant on duty in the emergency department should be asked to review the patient. This allows for more definitive diagnosis and may prevent unnecessary delay in the management of the patient. Specialty non-consultant staff on call may refer patient to a specialty clinic after approval of the consultant on call. Specialty non-consultant staff should not give patient specific appointment dates to specialty clinics. The appointments should be as per vacancy on the schedules in the computer unless otherwise directed by the consultant. Consultants on call are at liberty to send patients seen in the emergency department to the appointment office for specific appointment in their own specialty clinic. However, where the patient is already being treated in that specialty, the on-call consultant should treat the emergency condition and send the patient to the appointment office to be booked for the primary treating consultant as per available space. The name of the primary treating consultant must be provided to the appointment office. D. Interspecialty referrals in emergency department. Where a patient needs referral to another specialist by an emergency department doctor to a non-consultant on-call doctor, and after examination and documentation, the latter considers the case not belonging to his specialty, the emergency department doctor should personally contact the on-call non-consultant staff of the appropriate specialty, and the first non-consultant on-call should be available till the second specialty non-consultant staff reviews and examines the case. If there is disagreement in accepting the referral, the first non-consultant on-call doctor should call his consultant to resolve the issue. In the event where the two consultants do not agree to whom the case belongs, the consultant to whom the case was first referred should admit the case as primary treating consultant, and the other consultant should follow the case till further tests or clinical findings point to a definite pattern and diagnosis. If need be, the departmental heads and the medical director should be asked to review the case in ward after admission. E. Follow-up cases in the ward. The primary treating consultant should follow up his patients until they are discharged from the hospital, unless formally accepted in writing by another consultant. Chronically ill patients who are referred to a consultant in other specialty should be followed up in the ward at appropriate intervals by the consultants to whom they are referred until they discharged. Discovery of complications is a joint responsibility of the primary treating team and the consultant seeing the patient on referral. Management of the new complication should be as appropriate by the same team. For inpatients who develops a problem requiring the attention of care of another specialty, the treating consultant should request via consultation form the attention of the desired consultant. Referrals to medical department should be to the specific units through the department secretary. Weekdays after regular duty hours, referrals should be through general physician, and weekends referrals should be primarily addressed to the general physician on call, unless otherwise indicated by the department's roster. Subspecialties with more than one consultant should have the weekdays and weekend fully covered by with consultant at all the time. Follow up the patient subsequently should be arranged by the physician who attend the patient on behalf of the specialty during the weekends. F. Interspecialty referrals of emergency cases in the wards. Inpatients requiring emergency treatment and management that need referral to another specialties should be referred to the on-call consultant for the appropriate specialty, who should then manage the patient and may continue to do so with the primary treating physician until his or her services is no more necessary. A non-consultant staff during off-duty hours at the request of a fellow non-consultant from the primary treating team should come and examine the patient and should write in the case note that he has seen the patient on behalf of the consultant on call for his specialty for the day and should inform the concerned consultant the next day about the case. The non-consultant should write in the case note as follows: patient referred by doctor, name of the non-consultant staff who referred the case, and seen on behalf of, name of the consultant from his specialty on call for the day. The treating consultant should inform the primary consultant in charge by phone the next day and request him to follow up the case. Where non-consultant staff has seen a serious case referred to him by his colleague on call, he should inform his consultant immediately. The colleague who referred the case to him should also inform the treating consultant of his group and request his attendance for discussion with the consultant to whom the case has been referred. G. Emergencies in the outpatient clinics. Patient attending outpatient department who develops emergency conditions should be sent immediately to the emergency department to be attended by the appropriate specialist on call team and the emergency department team. Prior to transfer, resuscitative measures should be instituted first in OPD by OPD specialty clinic team where the patient is being followed up. H. Emergency referral in operating room. Patient on the operating table that need urgent referral to a specialty as deemed necessary should be referred through the paging system to the concerned doctor needed, who should be part of the treating team until his or her services is required. In cases where a patient on the operating table suddenly develops cardiorespiratory arrest or myocardial infarction, referral should be made through the paging system with the use of physician plebe pager number for the concerned specialty to treat the patient, followed by direct contact by the treating physician. CPR is initiated by the OR team until the code blue team arrived to take over. If the patient is already stabilized, he or she should be transferred to the intensive care unit immediately for further observation, treatment, and management, and this is done by referring the case directly to the head of the ICU and followed by a written referral and transfer notes through the use of MOH referral form. All orders for referral and transfer should be documented in the patient medical record order sheet and progress notes. I. Referrals to and from the intensive care unit. Patients that need referral or transfer to intensive care unit should be referred by the treating consultant to the head of intensive care unit by documenting the referral order in the medical record progress notes regarding the need of transfer of the patient to ICU and sending the consultation referral form mentioning the reason of transfer and supplemented by direct contact whenever necessary. The treating physician discusses face-to-face with the ICU physician the case. When the referral form is received by the ICU physician, he or she comes to see and examine the patient referred. If the patient is qualified for transfer, an order is documented in the referral form and the case is accepted. If a bed is available, then the patient is accommodated immediately. If no bed is available, then the patient is booked for reservation as arranged by the bed management office until a bed is available. The ward nurse should frequently check ICU for bed availability. If a patient from ICU gets better and needs transfer to the general ward, then bed is to be arranged with the bed management office. Second, external referrals and transfers. The approved process of external referral and response implemented by the Ministry of Health should be adhered upon accordingly. All external referrals should use the approved referral form approved by the concerned hospital. All external referrals should use the fax system in sending the referrals request to the concerned hospital. Original of the referral form given to the concerned hospital and the duplicate copy will be attached to the patient's medical record. All responses should also be received through fax messages. A referral letter with the use of the approved form from the concerned hospital and with mentioning of the reason for the patient's admission, patient diagnosis, brief summary of hospitalization, therapies, consultations, non-invasive procedures to date, medical list, condition at the time of transfer and the reason for transfer, and a medical report is made by the treating physician and will be sent by fax to the hospital concerned. All referral orders should be documented in the patient's medical record. If referral is accepted, patients are conducted to the concerned hospital by either nurse and or doctor involved in the treatment of the patient, including the patient's medical record supplemented by the laboratory and other investigations made for this patient. If the patient is accepted for admission, then the patient is endorsed properly by either the nurse or the accompanying physician and should be discharged from our hospital originating ward. The decision of transfer will be made by treating consultant. The patient to be transferred will be assessed just before transfer by the treating doctor, who will decide finally about the transfer. Reason for patient transfer should be valid and should follow the following provisions. Transfer of a patient should be facilitated upon the request of the patient's, his or her family, employer, or authorized representative. The patient needs further treatment and management wherein our hospital cannot offer. Administrative reasons, non-availability of beds. A patient is sent back to his referring hospital upon the order of the treating doctor. Any request for accompanying nurse and/or doctor request for hospital ambulance should be ordered by the treating doctor in the patient's medical record and should be arranged by the nursing office, team doctor, and social worker accordingly. Hospital ambulance for transport must be well equipped and maintained properly, ready for emergency measures to be given along the way. Procedures. 1. Internal transfer. 1. Attending physician will discuss the case over the telephone or by direct contact with the relevant clinician or specialist, making sure that the required service is available at referred department and beneficial to the patient. 2. Attending physician will write a medical report or referral form including clinical assessment for transfer, reason for transfer, procedure required, and sends it to the relevant physician or specialist as well as the medical director. 3. After securing consent from the receiving physician or specialist, the attending physician will write transfer orders in patient's medical record and details of correspondence communication with the receiving physician. Number 4, ward nurse will notify attending physician, supervisor, admission and discharge department, receiving ward, and dietary department of transfer. Document transfer on patient sheet as transfer out. Document transfer on census sheet as transfer out. Document transfer on supervisor's report form. Document transfer on inpatient order sheet by marking out diet. Check patient ID band for positive identification. Explain rationale of transfer to patient and/or family. Assemble patient medication card, cardex, sheet, and chart personnel effects. Assess patient's mobility and transfer via appropriate vehicle with effects to receiving ward, nurse escort to accompany patient. Transfer nurse give report of patient's condition to receiving nurse. Receiving nurse checks patient's identification band for positive identification and accept effects. Receiving nurse document on patient chart time of transfer and initial assessment. Receiving nurse orients patient to new surroundings. And family teaching should be done and documented. Number 5, the receiving physician must indicate whether patient will be received directly in the ward or ICU or will have initial assessment. 2. External transfer. 1. Appropriate medical report with relevant available lab data, radiographic finding, and reason for transfer must be prepared and dispatched by fax or by other means to the physician or hospital receiving the patient. It should include information regarding patient clinical status, stability or otherwise of patient vital sign, hemodynamic status, and whether patient needs ambulance with escort team, equipment, and monitoring system. 2. Patient and significant others company agent are responsible for securing a bed and acceptance at facility of their choice. 3. Physician may guide patient and significant others with the help of medical director and social worker as to where such services may be available. 4. The receiving physician or hospital must send fax or other means in writing report indicating acceptance of the patient. 5. Attending clinician should write transfer orders in patient's medical records. 6. The nurse shall assure the patient's medical records contain the following documentation by the physician: date of transfer, reason for transfer, name and location of receiving facility, agree by receiving hospital to accept patient, and evidence that the patient is sufficiently stabilized for transfer. 7. The transferring nurse shall notify her supervisor, who will then be responsible for notifying the nurse supervisor at the receiving facility. 8. Nursing supervisor, after coordination with the doctor, will arrange for the ambulance through emergency department and escort team as appropriate. 9. Endorsement. Physician to physician, nurse to nurse, and ventilation issues by anesthetist to his or her counterpart should be endorsed at receiving hospital. Both parties will sign endorsement details. 10. Receiving physician should sign the handover report and receiving nurse will sign nursing discharge summary, which will be filled in the patient's medical record. 11. In case receiving hospital offer their escort team and vehicle, patient will be endorsed at bedside here and handover signature should be taken from escort team. Patient's belongings will be given to relatives, company agent, or escort team. 12. Critically ill patient must be escorted by one of the treating physician or designees with 2 ICU nurses. If patients are ventilated, anesthetist and respiratory therapist will accompany the patient with necessary equipment and monitoring system. This is an example of referral form document. And here is another example of referral back form document. Approval of each policy is usually done by the preparing person, recommended by the department head, reviewed by the nursing supervisor, and approved by the quality director, medical director, and hospital director. Thank you.